We brought one of the robotic arms, as it is a twin robot, into a real operating room for the first time. We chose a day that would not interfere with the surgical operations being performed for our dear patients, ensuring no disruption from the patient's flow or the control of the environment. We brought this robot into the real operating room to see if our surgeon, who is a retinal surgeon, could handle this robot without having it physically in his hands and alongside him, allowing the robot to record the surgical movements he is performing. This way, later he can provide haptic feedback to his twin robot based on those recorded movements and a surgical student. The retina can receive these haptic feedbacks from the second arm of the robot, facilitating retinal surgery training. This is actually the idea behind the project. Today, we brought one of the robotic arms into the real operating room and used a donated eye that was not suitable for human cornea transplantation due to biological contamination. We are utilizing this eye for research and development, which will ultimately benefit patients. In this experiment, we are transplanting an artificial cornea onto the unsuitable donated eye to provide a clear view for the posterior part or the retina, allowing us to test the feasibility of the retinal surgery. I have completed the first part and transplanted a temporary cornea. To be more precise, a temporary cornea made of glass that has no therapeutic application. After removing the original cornea from the eye, I secured it to the bed and sutured it. Now our colleagues are getting ready to perform a vitrectomy or retinal surgery and see how easily they can carry out the actual surgical steps while handling the robot. This is happening for the first time in our years of work on strengthening the core. However, you might think that there are still significant challenges ahead before this twin robot can assist in a real operating room. One of the requests we had was to establish a preclinical laboratory to optimize the robot's ergonomic aspects and adapt it to the conditions of the operating room. This way we can bring it into a real operating room. Once the preclinical laboratory, which requires substantial research credibility, is established, we thought we might be able to conduct some of this training and testing in a controlled environment where the surgical routine is not disrupted.
This robot will actually be in the form of two similar robots. The name of this system is the ARAS ASIS system, which includes the haptic feedback system for surgical training. To explain it simply, the hand movements of a skilled surgeon are recorded and analyzed by this device, and the motion data and skills can be extracted. These movements are transferred to a second device electronically, which can allow the skilled instructor to correct the hand movements and the necessary haptic actions for the person who is in training. This version you are currently seeing is the third version of this robot. The first stage of laboratory testing has been completed and initial modifications have been made. The second version was tested in the Vitalab at Farabi Hospital last year in July, and the necessary modifications for this system have been implemented. Today we are pleased to announce that we are moving forward with another milestone, and the evaluation of mechanical movements and the structure of the robot in eye retraction surgery has been approved by our esteemed colleagues.
It was very exciting and a bit overwhelming for us that we could test the ARAS assist robot, which is for teaching vitrectomy, directly on the eye. Well, one of the challenges we face in teaching vitrectomy and training fellowship assistants is that, to be honest, many movements that we perform as surgeons, as experts, are done unconsciously. The expert doesn't even realize what movement they are making, as it has become so habitual. The advantage of the dual haptic system is that it can effectively transfer the master's hand movements to the assistant who is learning and being trained. On the other hand, when the assistant tries to perform a maneuver, often we don't understand why they can't execute a certain movement. It could be a subtle movement in their hand, in millimeters, that we can't convey. However, we can identify the errors in their hand movements through this system and communicate that to them, allowing them to correct their hand movements in real time to perform the surgical procedure better. Overall, it facilitates the transfer of complex and delicate surgical maneuvers in vitrectomy, which often involve movements at the millimeter and micrometer level between the expert surgeon and the fellow who is learning.